My name is Katie. I'm a patient navigator with Northwest Medical Specialties, and I'm also a member of the cancer support community. The cancer support community and Northwest Medical Specialties have joined forces to bring award-winning support programs and educational resources to patients and families facing cancer. As the largest nonprofit network of cancer support worldwide, the cancer support community is dedicated to ensuring that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. Through our partnership with CSC, we're able to offer our patients educational workshops, support groups, and social events. Today, Dr. Sabel Blau is going to be speaking first, followed by Dr. Tony Blau. If you haven't already done so, please change the view on your Zoom to speaker view. This is going to minimize all of the participants so you can see the presentation. Also, we are going to monitor the chat box throughout the presentation. So if you have any questions, please feel free to put them in the chat box. All questions are going to be saved for the end of the presentation. Also, we are going to have a raffle at the very end that you need to be present in order to win for. And please stay muted throughout the presentation to eliminate any background noise. All right, I'm going to go ahead and hand it over to Donna so she can introduce our providers.
Thanks so much, Katie. And thank you both Dr. Sabel and Tony Blau for joining us today. I feel very blessed that I get to introduce both of you. Dr. Sabel Blau is a medical oncologist who has been in clinical practice since 2001 after completion of her stem cell fellowship at Fred Hutch Cancer Research Center. In addition to her work as a breast cancer oncologist, Dr. Blau has taken leadership roles in developing breast cancer patients of excellence in her region. She's also very involved with clinical research programs at Northwest Medical Specialties, where she's the medical director for hematology oncology and is the head of precision medicine program. She is one of the founding members and the president of the Quality Cancer Care Alliance. She's also the immediate past president of Washington State Medical Oncology Society and member of All for Cure as a clinical oncologist. And then we have Dr. Tony Blau. Tony founded All for Cure after 27 years as a professor of medicine, hematology, and physician scientist at the University of Washington. His research has spanned gene therapy, stem cell biology, genomics, and cancer, consistently focusing on bringing the very latest research advances to patients with hitherto incurable diseases. At UW, he founded the Center for Cancer Innovations, which brings together a distributed network of investigators to help patients with advanced cancer. Tony co-founded the UW Institute for Stem Cell and Regenerative Medicine and chaired the Molecular and Cellular Hematology Center at the National Institutes of Health. He has authorized more than 84 scientific publications, and he diagnosed himself with myeloma in April 2015. Tony infuses All for Cure with an incredible sense of urgency to improve the prospects for cancer patients now and in the future. So without further ado, the dynamic duo of oncology, Doctors Tony and Sabel Blau. Welcome.
Thank you, Donna. That was a very nice review. So I would like to, am I in charge of moving the slides? Could I be co-host so I can move them? Or somebody else is running for me?
I can run for you, but if you would like to have control, I can go ahead and make you a co-host.
That would be great. It would be great, yeah. Have you? Actually. So before I get started, I gave this talk several years now in a row, and I'm going to present a similar information, but there will be a lot of a lot of information here that will lead to questions. There are some questions that were asked through email as well. So what I'd like to do is run my presentation first, and then I'll give the stage to Tony, and Tony will do his. And at the end, we're going to answer questions. You might have some questions. You can send them through the chat or just write down. I still don't have the control, I think. So if you want to just go to the next slide.
Okay, I made you co-host, so.
Yeah, it's not happening.
Okay.
Okay. So this program was developed by Cancer Support Community, and this is a content that was worked on independently, and outside experts reviewed it. So this is not my own presentation, so I have to present what they did. So they have the final control over the content of our programs. And it is also generously supported by Sanofi and Genzyme and GSK. And we'd like to thank them, as well as the local cancer support community and Gilda's Club that helped us to put this program together. Next slide, please. This is our disclosure. We don't have any financial relationships or affiliations. We both are the owners, have the ownership on All4Cure, however. Next one. Today's discussion will include what is multiple myeloma, which some of you know about it. Some of you might be new to the conversation or want to have a refreshment. So there will be some of that initial presentation on the content of multiple myeloma. And I'm going to go through the whole bunch of anything from diagnosis all the way to treatment and coping with multiple myeloma. Next one. Go ahead. Okay, so let's start with what is multiple myeloma. I like this slide because it actually, I'm a very visual person. I try to write stuff and draw some ugly pictures with the patients in the rooms. Now doing a lot of things virtual, it's not as easy, but I like to show pictures like this because it gives you the idea what is really a bone marrow. A bone marrow is inside the bone, outside. This is your leg bone, femur. And inside the bone, in the middle of it, there is this area called bone marrow where the blood cells are made. So multiple myeloma is a disease of a blood cell called plasma cell. And it is one of those many different lines of cells that are produced in the bone marrow, which makes both red cells and white cells, as well as platelets. And they are essential for our body to function in the ways that protect us from outside world infections and all the functions that go with the red cells and the platelets. So bone marrow makes all of it. And then inside the white cell section, there are many different cells that are made that protect us against the infections or have different functions in cleaning the body from bad incidents. So when a stem, where the stem cells, so the mother cells get made in the bone marrow, and then they turn into more mature cells, those plasma cells are made as part of these white cells, and they make what we call antibodies, which you'll see in a moment. And those antibodies are very different types of antibodies that protect us against infections. When in general, cancer happens because one cell grows out of control and the body makes repeatedly the same kind of cell that's not supposed to be made that way because it's out of normal, and eventually those abnormal cells take over the organs, and that's how cancer becomes a major problem. In the plasma cell or in the multiple myeloma situation, it's that plasma cell that starts with an abnormal cell that will make these abnormal looking plasma cells. In this picture, you see that there are normal looking cells and then there are abnormal looking cells, because when the cancer happens, the cells become not very noticeable or very different than normal cells. So then the abnormal cells, plasma cells, when it becomes cancerous, makes the antibodies. And that antibody would be, because there's only one type of cell growing as an abnormal thing, it's going to make same type of protein over and over again. So that's called abnormal antibody called M protein. And that's what we measure in the blood, and I'll tell you in a moment. One thing to know, a lot of people, I hear from patients, say, my father has bone cancer called multiple myeloma. It's not a bone cancer. As you see here, outside of the structure, there is bone, but this is coming really from a blood organ, which is bone marrow. And then it's also confused sometimes with melanoma, which is a skin cancer. It is myeloma, which comes from bone marrow. So it's multiple myeloma is a bone marrow cancer, basically. Next slide, please. So what can do these abnormal proteins do to our body? What can abnormal proteins do to our body? Well, when you have too many of these myeloma cells, which makes these too many abnormal proteins, it can cause a lot of different little problems that can, if accumulates, that can become real problematic. We call these symptoms of multiple myeloma CRAB symptoms. C comes from high calcium in the blood. When the bone marrow gets expanded and you make overproduction of these cells in the bones, then you kind of are approaching to the bone, you're kind of eroding the bone, what these cells can damage the bones, then it causes high calcium in the blood. And that the B is the bone pain and the fractures, because you have the expansion of these cells inside the bone. And even though it's not a bone cancer, but as the cells grow over and over, it can start causing weak bones and the fractures and bone pain. The proteins can be heavy, and sometimes too much protein in the blood will damage the kidney. So you can get into kidney failure with that. And then anemia happens, almost always anemia happens when people are sick. Anyway, even if it's not cancer, it's an infection or other causes. But in this situation, it can happen for many reasons. Anemia means you have low red cells. Because your bone marrow is occupied by these abnormal plasma cells more and more, the red cells go down. So you become anemic. Anemia can also happen from having kidney failure. So the symptoms will depend on how extensive the disease is and how the body responds to it. And so most myeloma patients do not have all these symptoms, or maybe none of it. It could be just a blood work or some X-ray finding that will make the diagnosis. Next one, please. So what causes this cancer to form? A lot of patients ask me, so where did I get this from? Well, cancer cells, like I said earlier, they start with one abnormal cell and overgrow, and then you can't, it has its own control. It has its own brain in a way. So it starts usually with one or a few genetic mutations that happen inside the cell. The cells contain thousands of genes, and those genes, if one of them gets mutated in the wrong place, will start causing this abnormal cell growth. And then these cells, these mutations in the plasma cells over time happen more often as we get older, because as part of aging, the cells get older, and then we also have longer exposure to the environment, whatever the cause that could be. I mean, there could be some environmental factors like radiation exposure, like it happened in Hiroshima when atomic bomb happened years ago. The survivors years later had multiple myeloma and leukemias because the bone marrow is very sensitive to radiation. But a lot of times, I mean, most of the time, we don't know why myeloma happened in the first place. It's all something started it, but a lot of times we do not know the cause. Next one, please. So who's at risk for myeloma? Myeloma diagnosis is not as rare as I used to think when I was a resident, but I'm talking about ancient years ago. So about 1 in 132 people in the United States are diagnosed each year. And it is the second most common, second to CLL, chronic lymphocytic leukemia. It is the second most common blood cancer diagnosed. The risk goes up as we get older, like I mentioned. African Americans have 2 times higher risk than whites getting this disease. Close relativity, we don't know exactly hereditary. People ask me that question, but we see in families having multiple myeloma, whether it's from the exposure or other factors. I don't know the answer to that. Men are more
Hey,
common than,
Sabel.
yes.
Sabel, I'm sorry to interrupt. It says about 1 in 132 people are diagnosed each year. That's not right. It's 100. It can't, right? That can't be right. It's got to be 132 out of 132 people with cancer. Maybe 1 is myeloma, or I don't know what that means, but there'd be
Okay.
tons of myeloma if that were. We'd all, each year we'd all have myeloma eventually. So
Okay. So
yeah.
we'll check on that, but thank you for pointing that out, Tony. If maybe somebody in the background can check on that, that would be great. This came from the resources that were double checked. So a man is more likely to have it if obesity is associated with this disease as well as other diseases. And other diseases, for example, MGUS. This is a funny word. People say, what is MGUS? It's a monoclonal gammopathy of undetermined significance. Monoclonal means one type, one clone. Gammopathy means that immunoglobulins that we talked about, which is antibodies. So monoclonal immunoglobulins of undetermined. We don't know if this is real disease, if it's going to lead into cancer or not. But 1 in 100 people in MGUS develop multiple myeloma. So there is a chance of this going into myeloma over time. So the CRAB symptoms, again, low blood counts, I said anemia. Anemia is actually present in 60% of the patients, and it can cause fatigue, weakness, shortness of breath, other symptoms like chest pain if you're too much anemic. Decreased kidney function, again, will cause weakness and fatigue. Bone damage will cause bone pain, and 85% of the patients have some kind of bone damage, but some very visible, some not. And the high bone turnover, like I mentioned, as the bone marrow expands, it touches on the bone on the outside, can cause the high calcium. High calcium will be pretty difficult problem to have, because patients usually present to the emergency room with this problem when they have confusion, mental status changes, constipation, appetite loss, and it can be pretty dramatic improvement after those symptoms go, after the hypercalcemia is treated. So about 10 to 20% of the patients with newly diagnosed myeloma will not have any symptoms at all. Next one. So what do we do to diagnose? We definitely have to have a good health history. Everything starts with talking to the patient and spending the most time there. And then a good physical exam, followed by general blood tests. We learn a lot from these blood tests, because myeloma is a blood disorder. It's going to give a lot of little information in the blood that will be very important in diagnosing and prognostication of the disease. And then we do have special myeloma tests. And then we can also use chemistries that are used at the diagnosis. Next one. Next slide. Okay. So what do we do after we do the general blood work? We get a urine test that usually is a 24-hour urine to calculate the amount of the protein floating around, if there is any, because it's not always that we see myeloma cells in the urine, but they can, or the protein, not the myeloma cells. I'm sorry, I said it wrong. Myeloma cells don't float around in the urine, but the protein will spill into the urine. So the urine test we do to check the amount of the protein. We do some bone imaging, not necessarily bone scans. We never use actually bone scans, but we use scans including PET scan, MRI of the bone marrow, and skeletal survey. In every diagnosis of myeloma requires a bone marrow biopsy, because not only we look at the amount of the plasma cells, but we look at other factors that will tell us if it's a high-risk myeloma or low-risk myeloma, which you'll find out in a moment. And then with it, there is a lot of biomarker tests as well. Next one.
Dr. Blau.
Yes.
Really quick, I did get an updated statistic. According to the National Cancer Institute, about 7 people out of 100,000 are diagnosed each year.
So I'm sorry, say it again.
The new rate for the cases is 7 out of 100,000 each year.
Yeah, so it's not like 1 in 132 like Tony was saying. Thank you, Tony. He knows this better than any of us, right? Okay, so I didn't pay attention to it. Actually, it doesn't make sense. So sorry about that. I have to tell you about these tests. We don't have to go too much into detail of this, but CBC and CMP are our most common tests. CBC is the blood counts, red cells, white cells, platelets. CMP is when we look at the calcium, kidney functions, liver functions, and bone status. Beta-2 microglobulin is a very special test. We don't do this all the time. We do it at diagnosis and at times to stage the disease. It is a protein that is very specific to multiple myeloma. LDH is an enzyme that we use how much activity there is in the blood, just like beta-2 microglobulin. These are important to stage the disease. What's the stage 1, 2, 3? Basically what I'm talking about. This shows the activity. Serum protein, electrophoresis, it shows us the protein, that M protein I'm talking about. And that is very common test we do at diagnosis and in follow-up. And then this tells us how much myeloma there is. And when the myeloma goes away, that protein goes away too. That's the M spike we see. And then we have different types of antibodies. They are called heavy chains or IgG. Actually, they are called immunoglobulin. And there is a heavy chain and a light chain in an immunoglobulin. So they are named G, A, and M. There's others too, but these are the 3 types we pay attention to, the most common being IgG, and then the others. And then the free light chain is in that Y-shape chain that immunoglobulin has. There's a little light chain at the edges of it, and that's either kappa or lambda. So when I tell patients your passport of myeloma, your type of myeloma, you need to know this because this is important. Is it IgG kappa, IgA lambda? Well, I think it's important to know because those are the things we'll be watching in the blood if they are coming down with treatment or not, or if they are coming back up. And then the urine protein, as I mentioned, we do 24-hour analysis, and the little protein will do the electrophoresis to detect the protein. And after 24-hour urine is collected, we will check how much protein there is there in a 24-hour urine collection. Next one. So MGUS, like I said, monoclonal gammopathy of uncertain significance. This is something what we call, in the easiest way to explain this, is precancerous situation before myeloma develops. But most of the MGUS patients do not develop multiple myeloma. This is a condition that requires watch over the years, and sometimes as frequently as every 3 months with the blood tests I mentioned, and sometimes as long as 1 year in between, depending on the risk of the progression. And only 1% risk of progression per year to multiple myeloma, although this is, again, very superficial information. If you dig into different types of myeloma, different types of proteins, like IgA has a much higher rate of conversion to multiple myeloma. And bone marrow biopsy is less than 10% plasma cells in this situation. In the smoldering myeloma, it is multiple myeloma, but it's asymptomatic multiple myeloma. And in smoldering myeloma, it might take years before it goes into full-blown myeloma that will do any of the harm that we talked about. So a lot of times we watch those patients, but that we do look at the M proteins are not as low as what we see in the MGUS. They are like myeloma level. But the bone marrow biopsy cells has more than 10%. It's enough to have a 15% plasma cells in the bone marrow to call it smoldering myeloma. If it's 70%, I wouldn't. It would be multiple myeloma. But these patients specifically have no symptoms or signs of myeloma. Next one. Plasmacytoma is when you have nothing but just one area, one mass. You have this expansion of the bone marrow that made a mass, usually in a bone, but sometimes even outside of the bone. It could be in the internal organ areas, and it could be just one accumulation of mass, rather than multiple, meaning many masses. And then, of course, the active myeloma, you have to have at least one Krebs symptom. We talked about those: calcium, renal failure, anemia, and bone fractures or pain, more than 3 grams protein, and more than 60% of plasma cells would actually qualify it by itself, but then it would still be important to have one of the other conditions. These patients usually are symptomatic. They present with something, weakness even is a symptom, and then diagnosis is made. Next one. So I think so you have in multiple myeloma, malignant plasma cells in the biopsy and one or more CRAB features, or if you have one or more high-risk features. Smoldering myeloma, like I said, 10 to 60%, more than 60% would go into myeloma. No CRAB or high-risk features, 10% of risk of progression per year to active myeloma. And like I said, MGUS, much less of all of these. Of course, there are no symptoms, and only 1% risk of progression to multiple myeloma per year. Next one. So those are the, again, reminder of the CRAB features. So plasma cells more than 60%, and seeing plasma cells in the bone marrow, it would make the diagnosis as you see here. And the other one is MRIs. MRI bone marrows is what we do today. When I was in residency, we used to do bone scans that turned out to be not very helpful because it doesn't pick up multiple myeloma as much, but whereas MRIs are extremely sensitive. So MRI of a bone marrow, one or more lesion, and of course, very high free light chain ratio. Those are the high risk features. Next one. So here is matching the right medicines to each patient. We try to do it as simple as, let me put it this way. We risk stratify patients, low risk, medium or standard risk, or high risk. How can we take this information and give the right treatment? Because not everybody needs the same treatment, deserves the same treatment, or will respond to the same treatment. So you have a myeloma cell, you do a deeper analysis. This is why we need the bone marrow, because bone marrow not only shows us that 60%, 10%, whatever, but it tells us what is going on in the deep chromosome level. You can do chromosome analysis and see 46XX or 46XY turning into some abnormalities. Those abnormalities will give us a prognostic factor. It's a risk factor. FISH test is a very, very common test. It's a very specific group of genes that are tested by this because they are most commonly found in multiple myeloma, and they have most important risk levels. Like some gene mutations have actually good prognostic myeloma, whereas the other ones are high-risk myeloma. And of course, there is more detailed work that can be done by looking at gene sequencing and all that kind of stuff, which we don't do as much in clinical practice. We use mostly FISH, and sometimes, and a lot of times actually at diagnosis, cytogenetic analysis. Next one. So these are the stages. For some reason, I never look at the stages most of the time, but patients are very interested. What stage am I? To me, what's more important is the prior slide, the type of the myeloma, the biological type. But this is also important because this basically tells you if you have a very low amount of disease, you don't have very high risk features, you have normal enzymes in the blood, you're stage 1. Stage 3 is the opposite. You have all these bad characteristics in the cytogenetics, very high LDH, meaning active disease. Remember, it shows the activity, the volume of the, not the volume, but the activity of the disease. And stage 2 is in the middle. Next one. Next one. that's important to us to decide how aggressive we're going to be treating these patients in the beginning, including a stem cell transplant or not. So next one, before this one, please go back to the old slide. This is important. I think I don't like to say this. I actually even talked to a national expert before this. He brought up the multiple myeloma as like a diabetes. There is no cure, but like diabetes, it is a chronic disease. And thank God we have so many drugs. Only if we knew what to do with them, we can put people in a chronic condition over time. And yeah, that's what we try to do. Next one. So treatment planning, we have to take all the things I said before, how we made those numbers, the diagnosis, large volume, low volume, high risk, low risk, but put the patient's other health factors. What we call that is comorbidities. What's the other health conditions? Somebody who has no health conditions but very sick from the disease would be treated different from someone who has multiple comorbidities and not as sick. We would have an approach of more aggressive or less aggressive upfront so that we don't make the sick patients already sicker, but still treat them aggressively enough to put them into remission. So age is important. Also, of course, we always forget to say it as oncologists because we're so focused on treating patients, the values, the goals of care, all of that is very important. Next one. Next one. Okay. So this is another way of saying it. At the end of the day, this is the middle portion what matters, patient preference. When I say that, I don't mean I will give you all the information and you make the choice of getting treated or not. Because if a patient tells me after we discuss everything as the physicians and the experts and say, look, you have a chance of being treated and you will have hopefully a healthier life in the next, I don't know how many years, but this is a treatable condition. And if a patient says, absolutely not, I'm not going to do anything, I would like to be making that shared decision making with that patient because unlike the old times, when I started multiple myeloma treatment in my residency fellowship time, we had 2 drugs and we had a 7-month survival. I mean, we put patients on hospice if they didn't want treatment because we didn't have anything else to offer. But multiple myeloma is a different disease now. And in fact, so many of these treatments are not as side effective as some other diseases that we treat. Therefore, I would want to be honest with the patient about their expectations, their goals. But unless somebody really is opposed to any treatment to begin, almost every patient with multiple myeloma might have some treatment option. But again, patient has a decision making is what we're trying to say here. Next one. So the overview on the MGUS and smoldering myeloma, most of the time, we just closely observe these patients and do not treat them. And smoldering myeloma is tricky because the new information coming on, there are some high-risk patients that will turn into active myeloma within 6 months or sooner, or even later. It's going to become a more aggressive disease. So we might sometimes treat those patients, and there are clinical trials going on for that. But at this point, unless there is a clinical trial or somebody really special, these are wait and watch options, the MGUS and the smoldering myeloma. Active myeloma has an induction therapy, so everybody starts a good treatment that's almost always effective in almost myeloma patients, and then get into a stem cell transplantation if recommended. That's still induction. It's still induction. That's still in the beginning part of the treatment. And then the maintenance comes. Maintenance is a treatment that usually happens in these days, we're doing it indefinitely, but for many years. And of course, if the disease comes back, we change the treatment. We call them 2nd line, 3rd line, 4th line treatments. In addition to the chemotherapy, actually, I should say myeloma treatment, because a lot of them are not true in the true sense chemotherapy. There are targeted therapies and other treatments, but we also give bone strengthening medications for multiple myeloma because it involves the bones as it expands from inside out. Next one. So treating treating MGUS or smoldering myeloma, as I said, is the active surveillance, is what we do as physicians. But patients, of course, need to have their healthy habits, diets, and all of that lifestyle changes, relaxation. You know, over worrying about things is not going to help anything because we all know, you know, your mood, your immune system is very important to avoid the disease progression. So if you have a good, healthy lifestyle, is going to be very helpful. And well, it's the last bullet point is easy to say, very hard to do. Focus on what gives you pleasure now instead of worrying about the future. If you can listen to this advice, that would be wonderful. I try to listen to that advice myself every day. So next one. Okay, so these are the type of treatments. I made a mistake of saying chemotherapy. Chemotherapy is only one portion of the treatment options. And believe it or not, today we use less and less chemotherapy in multiple myeloma. It's usually immunomodulatory drugs. We call them IMiDs or IMiDs, help the immune system find and attack the multiple myeloma cells. Proteasome inhibitors, they cause the cell death in myeloma cells. Velcade is an example to that. Monoclonal antibodies like daratumumab attach to proteins on the cancer cells specific to those myeloma cells and help the immune system kill the cancer cells. And the steroids are, believe it or not, a part of the myeloma treatment. It's actually, it has anti-myeloma effects. So it's not that we're not giving the steroids to help with the chemotherapy side effects. We give them as part of treatment. Next one. Stem cell transplant, basically what it means, and there are two types, auto transplants and allo transplants. Auto transplants, when we give high doses of chemotherapy, so high that if we don't rescue the bone marrow will be done and you'll never survive. So what we do, we collect the cells from the patient, or we do it with an allogeneic donor. That's a completely different situation. Treatments are different, but we give somebody very high dose chemotherapy and then give their cells back. Within 12 to 15 or 16 days, those cells in the bone marrow find their way and grow back. But now they are clean cells because we do the stem cell transplant after the patient is already treated for multiple myeloma. And supportive care drugs and radiation is important because there are sometimes situations where the bones are very tender or fragile. So we want to treat them before they get broken easily. And the bone strengthening medications are just tremendously important because they not only have the healing effect on those bones that were damaged, but also they have effect sometimes against the myeloma cells as well. So they are really important. And of course, we do other treatments to treat the whole body, not just the cancer cells, but the whole body. Without it, we cannot support the patient fully. Next one. So these are some names. When I talked about immunomodulatory drug, I mean Revlimid, thalidomide, and something is missing here, which is called pomalidomide, which is Pomalyst, comes in the Revlimid thalidomide group. Proteasome inhibitors, Velcade, Kyprolis, Ninlaro. And if there are myeloma patients, and I see some here from even my patients, some of you already got these medications. Most of you got the Velcade and Revlimid up front. Thalidomide is not as common anymore, but there are still areas that we can use that. The chemotherapy drugs, there are only two very effective drugs, Cytoxan and Melphalan. There is more, but we don't use them anymore. That's an old-fashioned treatment. We use them only in certain situations. Steroid, dexamethasone is a steroid, or Decadron, and prednisone. And the monoclonal antibodies, it's not only daratumumab. There are others coming into the market, but again, it's not mentioned here. Next one. So here is the frontline treatment. Induction, when we do these treatments, RVD, VCD, Revlimid, Velcade, all of that. Consolidation with the stem cell transplant. So this is the first line of treatment. And then we put patients into maintenance. It's usually one of the drugs that we use in the induction, Velcade or Revlimid, or others could be too. And then the relapsed, when patients come back with the disease, we give them a different line of therapy, usually a different kind of treatment that was not used before. But in multiple myeloma, we can sometimes recirculate these drugs because it works when same drug is not used for a while. Next one. So these are the regimens, and I'm not reading all of these. Next one is the treating a relapsed and refractory myeloma. So patient, this is myself is a whole different situation. Honestly, what I do as a physician here and what my partners do and a lot of doctors do, we send a post to all for cure and say, patients' numbers are coming up. I am thinking of giving this. Are there any suggestions? What's happening right now? This, the fish, the biology I showed is becoming very clear that not every drug is perfect match with every single patient. So different biologies, different fish results, different genetic results, and different other factors, not just those, will be important to know from other patients' experiences. And so, and then of course, what's recommended at NCCN. There's a huge big list, just like the prior slide on the first line, huge big list for the secondary line therapy too. So it's really an interesting era where we try to put the whole picture into place: symptoms, biomarker results, risk of another relapse, what patient received in the past, general health, all of that. And then, of course, we always look at clinical trials. At Northwest Medical Specialties, we have a big research department, and we not only treat patients according to guidelines and what needs to be done in a cutting edge, and we have access to all regular drugs, but we pay a lot of attention to clinical trials. Because of the clinical trials, we are where we are today with all these innovation of these drugs. Next one. So the drug treatments, it's many treatment for multiple myeloma, even in later lines of treatment, is drug combinations at different times. And like I said, same options as above available for active myeloma, plus other new agents in clinical trials can be an option. So this was mentioned before. I'm not going to go into the same explanation, but we do a lot of supportive care to treat myeloma patients. Next one. So possible treatment options. Next slide, I think. Yeah. So these are the drugs. And then I think we have another one here. So these are the first relapse on Revlimid. These are the first relapse on Velcade. These are the first relapse off treatment or maintenance. So what this tells you, if you're already using Revlimid at the time of diagnosis, you switch it around and you do different combinations. If you're already doing Velcade, you change the treatment around and you do different combinations. As I said, we have just so many options. And in this case, I really like the ideas of the experts in the field, and we have access to Dr. Anderson at Dana-Farber, Dr. Bensinger from now Swedish. She used to be my mentor at the SCCA. Different kind of experts, and their opinions really matter, as well as what we know in the in the literature and how we follow the literature. Next one. Again, one more. Okay, here we go. So can you go back? So this is possible treatment options again for relapsed myeloma. So this says second or later relapse. I mean, this tells you, this gives you a little glimpse of course, I'm not going through all of this with you all because it's a different language, but so many different options, so many different combos that can be given to patients. Next one. So the clinical trials can be an option for any stage of multiple myeloma, like I mentioned. Models of care, precision medicine model, versions of existing myeloma drug types, drug combinations, test to track multiple myeloma. This is very important. So minimum minimal residual disease, MRD testing, minimal, not minimum. The MRD testing is important because patients who have MRD negative status, if they achieve it at the very first line, and if they stay with MRD negative status, they have a better prognosis. So we actually pay attention to it, and every time patient has a stem cell transplant, we follow it with MRD testing. Next one. These are the bone supporting medications. There are different drugs there. We use a lot of biphosphonates. You might have heard the name Zometa, even if you have another disease and listening to this conversation, you know that those are the drugs that we give for bone disease. And we also give a drug called denosumab. That's a special antibody inhibitor. And that's a very special drug for treating myeloma as well. And these are both strengthening medications. Now, all other drugs, vitamin D, calcium, pain medications, we do radiation, like I said, to reduce the pain. We sometimes give certain drugs like gabapentin to reduce the numbness that happen from myeloma itself or from the drugs. And of course, orthopedic surgery is a possibility as well. Next one. Okay. Your healthcare system. So what is said is that you have to find a hematologist oncologist who's experienced in treating multiple myeloma. I cannot agree with this more, but we're living in a world where there is a lot of research going, and the information is growing so fast, so exponentially in every field, including multiple myeloma. We are at a point that even NCI designated cancer centers, they have different approaches to multiple myeloma. All those regimens I showed, I looked at Dana-Farber's, I looked at SCCA's, so what I'm trying to say is that look for a doctor who's very up to date. That's important. And you can have a second opinion in an NCI cancer center, or we can help you to have that communication with a cancer center like that. How I do it is by using the patient gets uploaded in L4Cure, and they do that kind of tagging those doctors from different places and working with those doctors to get additional opinion, because it's really important to get that second and additional opinion. The patient and the team, not just the doctor, but the team that's involving that. I have a team, it's a blau team. The blau team is very important in your care if you are my patient. Same thing goes with the reach team and the Senecal team. So talking openly about concerns and problems with the team is very important. And of course, you need to feel, and this is not just multiple myeloma, in any cancer patient and doctor and the team relationship is so special that it's not about me telling you this is what it is and you do what I say. It's really about developing that relationship, not just you have that feeling that you're listened to, but also I have the feeling that I am learning about this patient. I am understanding this patient better to serve her or him better by understanding their goals of care and what they get out of this. And again, we already talked about second opinion. Next one. Yeah, so everyone has the right to get a second opinion. If you feel your doctor is making you feel like, oh, I'm the person and you can only stay with me, go away from there. You should find a doctor to be open to have for you to have a second opinion. In fact, encourage you to. In fact, you should find a doctor that will pick up the phone and they will do second opinion for you. And that's what we try to do with our patients, because talking to other experts, even talking within our own practice with other doctors that do this kind of work, we do this every day. You may not know that behind the scenes, but we do it all the time. Now, when I don't feel comfortable about what I'm doing or I want to get confirmation, I ask someone else. And that's where also I go to All4Cure, because they also ask help from others on our behalf. Next one. So palliative care services is something we pay a lot of attention to. In fact, I'm very proud to say that we have had a palliative care program. Susan Juflis has been helping us with that. And she trained at Harvard, and she's very good, but she's by herself and not alone. And she trained all the other APPs. But we recently hired a very superb palliative care doctor. He's going to start, I think, soon. I don't know when exactly. He's a team member, and we're also looking at a company outside outsourcing some other activities that can help our patients with symptoms, because we believe in palliative care, and palliative care is always mixed and misunderstood with hospice, end of life. No, we believe in palliative care from the moment of diagnosis and all the way to whatever, survivorship or death. Whatever is happening in that road, patients need that close contact with their physician and someone else that can give additional support that they need. So it is appropriate at any age, at any point, and it can help anything from symptoms all the way to the emotional impacts of this problem and the treatment side effects and all that stuff. Next one. So open communication is important. I think that every patient should be their own advocate. I don't think patients should be afraid to ask questions. I find that sometimes they don't feel comfortable and they want to go and seek another opinion, or they want to say something and they're afraid, so they take the treatment. And it kills my heart to know a patient did the treatment just because I wanted to. I wanted them to have it. So talking, being the advocate, explaining what the symptoms are really, having other family members help you with the translation of that information sometimes. We're open to that. I mean, we work with family members, we work with caregivers. It's really important that you told side effects and what you feel about it, how it impacts your life in the true manner. It doesn't mean we're not going to give you a chance to treat you. It means that we need to assess everything and just put ourselves back and think about it again. Doesn't mean we're not going to treat. On the contrary, we're going to continue to treat most of the time. And we do have a naturopath in our practice. My husband can tell you that he was so opposed to having a naturopath. And I don't like people to go out there and do some alternative treatments they call. This can affect your treatment. So we brought a very good naturopathic group to our practice. And when Tony got diagnosed, I told him to go see him. First, he said no, but he decided to go because of his neuropathy. And it went away and he was able to take his treatment. So he says, as a physician, 3 things I thought I wouldn't do. One of them is having a naturopath, and he now has a naturopath. So don't do over-the-counter medications or the herbs without talking to your health professional, and try to seek the correct info and go to your team, ask their opinion. Next one. And ask questions. I already said this, I think. Asking questions is important. As you see, I like to talk, so I just will dominate the conversation and keep talking. So I shouldn't be doing it because Tony will not have time, but ask questions, we'll answer. Next one. Oh, I guess there are many questions you can ask. This is what it says here. So the summary, before you choose your treatment path, you should know first of all, what is multiple myeloma? What's the risk? What's the stage? And what do you do with all this information? You know your team and side effects that you would experience from each treatment. We have chemo teachers because of that. If you want, get a second opinion, third opinion, fourth opinion. And if you haven't, sign up for All for Cure, because it's going to do a lot of it for you. Your past experience to treatment, if relevant. And that's really, you should understand that, because we actually think that comorbidities and past experiences and past response to treatment, it closes the loop. It's very important to take everything into consideration. And every patient should know if there is a clinical trial, and they need to sign up if there is one for them, because it improves the care. Clinical trial is not just about helping others, which does for sure, but it's about helping yourself in many ways. One, it's going to possibly tell you more about your disease and how you can get benefit from something that's never been used or has not been used in this manner possibly. But it also provides a structured treatment. You get to have a research nurse, research coordinator, data people, they are all around you to support you in addition to your doctor's original team, which is very helpful. There are studies that patients who are treated on clinical trials, they actually do better, even if they were in placebo arm, which we never do just placebo, by the way. Clinical trials always are designed to give something, plus minus something. Next one. Coping with multiple myeloma. So I think you guys, if you're here tonight, you probably have paid a lot of attention to all of these things. What I'd like to say, other than, being careful about heavy lifting, because this involves the bones and you can have fractures. Go into chiropractor without checking with your doctor first or getting assessed. You have to be careful about your bones. But one of the most important things I'm going to tell you is avoiding the infection. Number one killer for multiple myeloma, even if myeloma is not present anymore, even if it's cured, which happens sometimes, but most of the time it's a chronic disease, like I said, but even if it's in remission, infection can kill people. So I think this is really what we need to remember and take action, precautions. Next one. So first of all, is there a prevention for multiple myeloma? We don't know. I mean, I guess if you're a radiology technician, you should wear your, aprons, make sure that you don't get exposure to radiation. I think that's the extent I could go into prevention. There could be no early symptoms. Remember that, because myeloma might be present in full blown, and it may not have symptoms. The goal of the treatment is to live as long as possible with the best quality of life. Honestly, my goal is to cure this cancer. But anyway, let's just put it aside. And it is really important to think about it. Live as long as possible. That could be decades. Treatment of myeloma is so good now. Sometimes people live decades. Be honest and open when you talk to your healthcare team, so they can give you good advice and they won't keep doing the same wrong thing if they are. Clinical trials, we talked about it, and people can learn to cope with the diagnosis for a long time by being empowered to gain control, knowledge, and support. Knowing is everything. Next one. Okay, I think I'm done. It's exactly an hour, so
Yeah,
I think what I'm going to do is I'm going to give it to Tony and mute myself.
Okay, sounds good. And I'll share my screen and get my slides going. So you guys have already heard about Sabel and I. I was a professor for many years at the University of Washington, a hematologist, and then I got multiple myeloma. And that's a picture of me to prove that I have multiple myeloma. This is a picture of me on a gurney with where my doctor, Pam Becker, is doing biopsies. This was now this coming April will be 6 years since that happened. And from my now reluctantly patient's perspective, I came to appreciate a problem that I really hadn't thought of in the same way previously. And that is that I've had multiple different treatment choices. And actually the actual number of choices is way more complicated than is reflected here. So tons of decisions to be made and very little information at hand to use in arriving at what I thought would be the best decision for me. And even though I've been studying this stuff pretty much my whole life, I've been flying by the seat of my pants. And what I most wanted to know was what were the treatment choices and the outcomes of every other myeloma patient? What did they do and what happened as a consequence? And because that information didn't exist, they started All for Cure. So All for Cure really has three core constituencies: patients, clinicians, and researchers. And with the patients come their caregivers. With the clinicians come other personnel in the clinic. To register for All for Cure, you can just go online to our website and register as a patient. It's pretty easy to get registered. And then once you register, we ask that you complete HIPAA release forms that we send and we help with all this stuff. To get HIPAA release forms signed that allow us to access all of the medical records from all of the institutions where patients received care. And from the medical records, and sometimes they look like this, gladly not very often anymore, but from medical records from many different institutions, sometimes we pull together information that's displayed on each patient's personalized dashboard. This is the team that does it. This is a picture from yesterday morning. We're all meeting by Zoom, super smart young. We're all just super smart young people. These guys are recent college graduates, very, top of their class, interested in medical school. A couple of them are going to medical school. Have become very learned in multiple myeloma. And what this team does is create each patient's personalized dashboard. So we take away the patient's name, we give them a unique identifying number, and we show then this detailed history of all of the treatments that the patients received, and these labs indicate how well those treatments have worked, things like M protein and free light chain levels that we all monitor, but then you can click on or off different labs. And I should just say a ton of effort goes into trying to make sure that this information that's displayed here is accurate. This is a narrative, a summary of the patient's history that describes in words what's shown here, but also includes other information like other illnesses, diabetes, high blood pressure, heart disease, stuff like that. Excuse me, this is a kind of an about panel, a high level demographic view of kind of just general things, patient age, gender, whether there are any, molecular features of note in their myeloma. And then this is a discussion panel where the patient or a community now of over 1,300 participating patients, clinicians, or researchers can post comments or questions about each patient's situation. Clinicians also participate, as I've mentioned, and we have over 70 participating oncologists, both colleagues of Sabel's at Northwest Medical Specialty, Andrea Veach. These are just two examples of Andrea Veach and Frank Senecal, but many other oncologists in Sabel's group. And then also world-leading myeloma experts, some of the best-known myeloma experts in the world also participate in All for Cure. And so if thinking about it from the patient's perspective, what does All for Cure do for me? One thing that I think is super helpful is you can keep all of your medical information in one place. It's been organized and distilled and condensed and unified in a really thoughtful, comprehensive way, kind of a cool visual display. And you can share this information with your doctors, with family members. You can use our search function to find other patients like you, and then you can get access to an external network of expertise that will address comments or questions related to your specific situation. Just a few words about ways in which patients have benefited. We've helped, we help patients every day. I think we've helped hundreds of patients who participate in All for Cure. These are just 3 different ways in which patients have benefited. This is a marathon running 61-year-old Alaska Airlines flight attendant who developed a really terrible myeloma, ended up in hospice, but through suggestions rendered by 2 experts on All for Cure, in implementation of those suggestions by her doctor, she's able to leave hospice and go on to get 2 stem cell transplants. And so this just shows we can bring outside expertise to bear on a patient's problem. And when an expert posts a comment or suggestion on All for Cure, that's visible to an entire community of now over 1,300 participants. So it's like giving a megaphone to an expert, and their thought about one patient could obviously have implications for other patients who participate in All for Cure. This is a patient who learned through her participation in All for Cure that her treatment was different from most of the other patients on our platform, and it turned out it's probably inferior treatment. And so after learning that, she decided to change doctors and went on to receive better treatment. And so this is the idea of democratizing knowledge, so that a patient can know how their treatment compares to today hundreds, but eventually tens of thousands of other patients in a way that's not constrained by geography. You could live in Nome, Alaska, and know how your treatment eventually compares to thousands of other patients. And this is a patient who was not responding to his initial treatment, switched to an alternative treatment. Many of you will be familiar with, called carfilzomib, pomalidomide, dexamethasone. That worked well for him, and he stayed on it for a few years. But then insurance said, hey, this isn't approved for this indication. We're not going to pay for it. And so we were able to show the insurance company that not only did this regimen work for him, but it also, this identical approach worked for another patient on All for Cure. And based on that information, the insurance company reversed their decision and agreed to pay for his treatment. So here I want to just tell a little bit of a story about an issue that I don't think is adequately appreciated by myeloma patients. And it's one of the real take-home points that I've come to learn since starting All for Cure. So this guy, Bard Richmond, it was an amazing person, became a really good friend of mine. He is a very successful entrepreneur. He had started this company, Active Voice, that he sold, I think, to Cisco, still when he was in his 40s, and I think he made a ton of money from that. Prior to that, he had his own rock band, super impressive guy, super dynamic guy. And when he got myeloma, I got to know him, and he became I'm the first patient who enrolled in All for Cure. We're up to, we have, over 1,400 participants, but I'm MM1, Bard was MM2. And I learned a ton from him about, starting businesses and stuff like that. But this is Bard's All for Cure dashboard. When you go online, live on the site, it's cooler because you can hover over each of these things and see what each of these treatments represents. But this is just showing, this is an initial set of drugs called Revlimid, Velcade, dexamethasone. You would see that if we were live online instead of showing a slide. These are labs of his free light chain levels. So these are abnormal proteins secreted by his myeloma cells into the bloodstream. And what you can see here is with starting this treatment, his myeloma is responding. The levels of the abnormal protein are going down. And here he's getting a stem cell transplant. Again, it's cooler if we go online. You can see it's actually a stem cell transplant. But I remember, trust me, this is a stem cell transplant. Here he's getting some Zometa, some Revlimid maintenance, bortezomib maintenance, and his myeloma is staying under control. here he switched from bortezomib to Ninlaro because he was a huge advocate of, oh, what is the thing you get in when you go to the Hood River in Oregon? It's very windy. You can do it's some kind of, you have the parachute. You're on your like surfboard kind of thing, and you're jumping on the water and stuff. I forget what it's, kite surfing or something like that. He was very good at that. And he wanted to go to the Hood River and kite surfing, so he stopped his bortezomib, switched it for Ninlaro, and that was associated with a slight recurrence of his myeloma. It looked like Ninlaro didn't work for him. So he got back on other treatments, squished his myeloma again, but it came back again pretty quickly. They switched treatment, kept it under control, but then it came back. And what you can see here is every one of these things that we're adding here is a different treatment, trying the next thing. These are actually early CAR T cell treatments. And so there's this mad dash to switch treatment as his myeloma is getting more and more out of control, less and less responsive to treatment until he died. And now that's just about 3 years ago this month, Bard will have died. But this pattern, you could draw an inverted 90-degree triangle around it. And that's a very distinct pattern. When you look across the patients that are in All for Cure, you see this kind of pattern, this inverted 90-degree triangle repeatedly in the patients who have died. And here I've just done screenshots of some of the patients who have had this happen as the way that often people die of multiple myeloma. And this is not a complete listing. This is just a list that I got tired of taking screenshots, but it's super common, a super common way of dying from multiple myeloma. And this is just another kind of more, this is an academic paper that again makes the point that myeloma over time becomes less responsive to treatment with each successive relapse. So my approach to my myeloma has been to just really try to hammer it hard, achieve this state where you can't detect it with the most sensitive tests. And this is a state called being minimum residual disease negative. So no evidence of minimum residual disease. On the All for Cure website, there's a little video about, we have a little video about, with many videos, one of which describes why I did that. But the idea is to try to, really, short of a cure. So in general, it's probably true that the vast majority of patients with myeloma are unlikely to be cured. So if we think that myeloma is really incurable, I would venture that maybe the next best thing is to knock it down to the very lowest possible levels until a cure is found. And that's kind of the approach I've taken. I think there's increasing evidence to indicate that if you can achieve this state of being MRD negative, you will, it's very clearly associated with better overall survival if you can get that and keep it. But being MRD negative isn't the panacea, and this is another dear friend of ours, a surgeon in Puyallup, Jack Hornberg, who is MM5. This shows, his myeloma treatment. His myeloma was under good control, but Jack died of an infection. And so I think being very careful and very thoughtful, as Sabel has said, about infections, making sure that you get promptly evaluated if you have a fever, if you're feeling ill, have a low threshold for getting checked out, making sure to take your antiviral medicines, making sure to take the flu shot, these days being incredibly compulsive about avoiding COVID. those are just, you know, super important for patients with myeloma because, you know, patients with myeloma have some of the worst outcomes of people that develop COVID because we are so immune suppressed. Even if our myeloma is gone, we're still taking drugs that can really significantly depress our immune systems. So the way I've thought about this, you know, and this idea of, you know, trying to stay in remission and trying to avoid these relapses, it kind of reminds me of a vortex. And you can tell this is a cheap little combination of two things that I found on Google. But, you know, I think of myself as this little, I think of myself as this little tugboat out in the ocean, trying to stay on calm water and trying to avoid getting caught up in this vortex. Because once you're in it, it can be difficult to pull out. And what I would say is at All for Cure, what we are trying to help our patients do is stay in calm water. If it looks like they are getting caught in this vortex, we work very hard to try to identify treatments and usually clinical trials that we think could be helpful in trying to break free of this force. Because it is such a common thing that happens in myeloma patients, other cancer patients as well, but really it's been one of the main points that has drives home to me in my experience with All for Cure. So we're just trying to, you know, all try to stay in calm waters if at all possible. And if we are caught up in this, you know, look for strategies that can help us break loose. And that's it. So yeah, that's all I have. And then happy, I'm sure Sabel's also very happy to answer any questions.
Hi, Dr. Blau. I have about 10 questions. Okay. Unless there's any out there that would like to unmute and ask. Otherwise, I can start asking these 10 questions that were given to us prior to the presentation. So the first one is, are there any new advances or treatments towards Waldenstrom's?
Mm-hmm. Sabel, do you want to comment on that?
Well, there is actually there are newer drugs, but I actually would like you to take this, Anthony, because I'm not a
Yeah. Yeah. So, well, you know, there are tons of there's tons of progress in general, and many of the treatments that work in myeloma would also work in Waldenstrom's. So Waldenstrom's, as you probably, you know, as I'm sure you know, differs from myeloma in a number of different ways. It makes a different immunoglobulin called IgM. IgM is another immunoglobulin, like, you know, like myeloma, but it has physical properties where that could lead to that protein causing problems that otherwise, you know, abnormal proteins that are associated with myeloma don't cause. And IgM can cause sluggish blood flow, for example, hyperviscosity that can lead to all sorts of symptoms that you don't typically get with multiple myeloma. There's a genetic basis for Waldenstrom's that's been identified, and a mutation that occurs in almost in the very large majority of patients with Waldenstrom's. And many of the treatments that work for myeloma would be expected to work for Waldenstrom's. One of the issues with Waldenstrom's is it tends to be a much less aggressive disease than myeloma. And so I think one of the questions that comes up then is, you know, you want to be sure that you are not, you know, that you're not treating Waldenstrom's patient too aggressively, because oftentimes it's possible to keep it under control with relatively low lower intensity therapy. But yeah, there are lots of, I think lots of, tons of advances in this area, tons of drugs that have the potential to be effective. And I think the trick is to figure out how to best apply those in a way that won't harm a patient with Waldenstrom's.
Thank you. I have another question that goes along with that from Frederick, and he's asking how Waldenstrom's differs from multiple myeloma, how contracted if known. He's heard mild tiredness can occur for regular rituximab infusion treatments for diagnosed Waldenstrom's disease. What is expected side effects with continuing the rituximab infusion treatments?
With the rituximab infusion treatments?
Yes, excuse me, yes.
Yeah. So, right. So if you had to vote which one to get, multiple myeloma or Waldenstrom's, I would vote for Waldenstrom's. I think everyone would vote for, give me Waldenstrom's. Don't give me, I'll exchange in my multiple myeloma for Waldenstrom's. So it's not a walk in the park by any means, but it tends not to be as aggressive, certainly as multiple myeloma is for most patients. That said, it's still, again, it's not, there are problems that you can have in Waldenstrom's that you don't have in myeloma, this hyperviscosity syndrome, for example. And rituximab is a drug that works in Waldenstrom's that's not widely applied in myeloma because it doesn't tend to work as well in multiple myeloma. I think tiredness is a very common symptom for patients with Waldenstrom's as well as multiple myeloma. And so fatigue is a big deal. It's a big deal for me, trying to be thoughtful about how you expend your energy and exercising and things like that. It is hard, I think, to figure out if you're feeling tired, what's that due to? Is it due to, in your case, the Rituxan? And me, is it due to, one of the medicines that I'm taking? If it is, which one of those medicines is causing it? Or could it be the presence of some underlying, still persistent level of disease that's making me tired? So I think kind of dissecting these things, figuring these out is really tricky, I think, in trying to, assign a cause to a symptom, to a specific thing. The most we can do is try to identify those temporal associations. If you feel tired only the day after you get Rituxan, and it happens consistently that way, well, I'd say, gosh, there's probably pretty good evidence that the Rituxan is making you tired. One thing that I would say about side effects of drugs is I would say it's important to be thoughtful about when are your side effects bad enough to say, okay, I can't take this anymore, I have to switch to another drug. And that can happen, of course. Drugs have side effects, and oftentimes they'll have side effects that are too bad, too difficult for a patient to put up with. But if the side effects are moderate, or if they can be adjusted in some way, if there's something that you can do to adjust these side effects, I would consider that, because I would be thoughtful about stopping a drug that might be working great for your myeloma just because it's not, it's creating some inconvenience for you. If it's for example, this is not great dinner time talk, but diarrhea is super common with lenalidomide, with Revlimid, and it can be pretty rugged sometimes. If there are strategies that one could take to address that would allow you to continue the drug that's still effective in treating your myeloma, I would suggest pursuing that first, rather than just saying, okay, I hate this drug, I'm out of here, I'm stopping this. Because the issue is there are other drugs that you can choose. There are lots of other drugs that are potentially up for consideration, but we don't know that your myeloma will respond to those other drugs as well as it is to this drug. Or in the case of Rituxan, you could say, you know, I'm out of here because the Rituxan's making me feel bad. But there's no guarantee that the other drugs will work. And I want to be thoughtful about the drugs that I take, not just for their current effectiveness, but I'm trying to cast forward about what happens in the coming years and trying to retain, you know, keep my options open and not burn through a lot of different options, trying to find a drug that makes me feel okay, and then potentially, you know, putting myself in a less advantageous position down the road.
Thank you. I have a couple more. Dennis says, I was diagnosed with smoldering myeloma 3 years ago. Are there recommended approaches other than just watchful waiting?
Yeah, like I mentioned in my presentation, the most common approach is wait and watch, but there are clinical trials looking at the higher risk patients. I don't know the situation for Dennis, but most of the patients do not require any treatment. And in fact, a lot of patients, we want to just, oh, let's go ahead and treat feeling when we first meet them. And then it turns out to be smoldering myeloma. Some of those patients don't turn into full-blown myeloma for many years, and they do so well that it's a great thing that we didn't start treatment. But there will be a subpopulation of patients that will benefit from treatment. So Tony, do you have from All4Cure database any input to that?
Well, there is this category that Sabel described, so-called high-risk smoldering myeloma. And there are different ways that people categorize high risk, but a really common way is called a 20-20, let's see, it's 20-22, I guess. So if your kappa, if your free light chain ratio is greater than 20, if the percent plasma cells in the bone marrow is greater than 20, and if the M protein in your blood is greater than 2, if you meet all those criteria, I think you have to meet 2 of the 3 criteria, then you're categorized as having high risk smoldering myeloma, and increasingly oncologists might suggest starting treatment at that point rather than waiting. But, you know, that's very recent stuff. And the fact that you've gone 3 years without treatment is good. I do think having a bone density scan to look to see how your bones are doing, seeing whether or not you might need one of these bone building drugs that Sabel had mentioned is worthwhile. And an imaging study with a PET CT would be typically recommended often, you know, once a year in a patient with smoldering myeloma. But, you know, if you have not progressed to multiple myeloma within 5 years of having smoldering myeloma, the thought is that your likelihood of progressing to active myeloma goes down if you can, you know, stay smoldering for 5 years. So, but, you know, there's a lot of individual, you know, aspects of this, of course.
Okay. Angela would like to know, she says, what success rate is for a transplant? Transfer.
We did not understand you.
You're breaking up quite a bit there.
Oh, sorry. Let me try this again. I would like to know what the success rate is for a second stem cell transfer.
Yeah,
Okay.
so second stem cell transplant is, yeah, it depends on a number of different things. It depends on how well the first stem cell transplant worked. And was that really effective in knocking down the myeloma? You know, if the first stem cell transplant didn't work very well, I wouldn't have a lot of enthusiasm for us, you know, doing it a second time. Another thing that people pay attention to is the interval between the first stem cell transplant and the second. If it's been, you know, 5 years and you did okay, over that interval since your first stem cell transplant, then a second stem cell transplant is often used in that situation. One thing that I would say is, it sounds like if a second stem cell transplant is being considered, then obviously that means that the myeloma has come back. I would just, be sure, if possible, to not allow to not go off treatment. What you see a lot of times is people want to stop treatment and because it doesn't make them feel good. And if their myeloma is relapsed, and especially if it's relapsed, more than a couple times, when you stop treatment, you really give it a chance to come up hard. And it can be really difficult to get back under control. And so I'm a big advocate of, try to get that myeloma under control, and then ideally stay on treatment to keep it under control. Try to keep your boot on its neck, and don't let it kind of come surging back if you can. But yeah, second stem cell transplant can work to kind of help get things back under control. But the duration of the effect of a second stem cell transplant won't be as long as the first stem cell transplant.
Okay, William asks, are there new clinical trials for folk who have had several treatment regimens over the past 5 years or greater? I have MM since 2010, and I have had about 5 different chemo/drug treatments.
Yeah, that's where that's kind of the scenario that many patients end up in, and you end up switching from one thing to the next. So that's where I think it's very, that's where I think, if you'd like to register for All for Cure, it's free. We would be happy to look at everything and tell you what we think. In your situation, for example, we can tell you what every other patient in All for Cure has done in your situation. We can tell you what their outcomes have been. It's still a relatively small database, but I think it's nevertheless useful. And we can point you, we know what clinical trials are going on, and we can try to direct you to a clinical trial that can help kind of address this really significant problem of, ending up on this feels like, gerbil wheel of getting one thing after the next. I think, it's really, if at all possible, really helpful to try to get on some treatment that can help you kind of keep your myeloma under control.
Yeah, there could be some clinical trials available, but we have to understand the type of the disease and all the other factors that go into it.
Gary asks what symptoms he should be looking for.
That's a general question.
Weakness, tiredness, extreme fatigue, bone pain,
Fever.
So fever, but fever is actually if there's an infection. I mean, it can come with infection. Usually what it is that sometimes it's very vague. People change behavior and they are irritable. They have some confusion. It could be just simply because of the high calcium levels. There are probably the most common. So we used to think in internship, when they are teaching us, somebody comes with back pain and anemia, that two things would make us, especially if it's a man, that those two things make us think, oh, you have to check the protein in the blood because it could be myeloma. So it's the anemia and anemia-associated symptoms, which is mainly tiredness, weakness.
But saying what you would watch out for, would be, if you have a fever, that's a big deal if you have myeloma. That requires, because that's a scenario where, patients with myeloma die of infections. And
but I think Gary's question is, if I'm not wrong, I'm knowing Gary, I think the question is, what symptoms do you expect to get if you're getting myeloma?
If you have myeloma, I
if
see.
you are having myeloma, if you're moving into
Yeah.
myeloma.
Yeah,
Yeah, so-
fatigue, pain, those kinds of things are yes.
But the infection is a big thing. I mean, I think I agree with you. People should pay attention to infection symptoms.
Diane asks, if someone has been diagnosed with MGUS, what are some physical symptoms that it might be progressing to multiple myeloma?
Well, it's actually pretty similar to what I said to Gary. I think those symptoms that come from the transition into having more anemia, more involvement of the bone, more kidney failure, which will probably the biggest manifestation is extreme fatigue and tiredness. You know, some change in the last 6 months. I have been having overtired, sleeping, taking naps during the day, which I never did before, or the pain. I think pain and weakness probably are the most common symptoms.
Daravan asks what the survivorship outcome is post auto transplant.
That's a Tony question. It's very variable. I mean, it depends on the low risk versus high risk. It depends on what induction regimen given along with the stem cell transplant. It depends on if an MRD, minimum residual disease, negative status is achieved or not. Tony, you have any addition to it?
Yeah, no, I think it depends a lot on your cytogenetic risk factors and stuff like that. But I can tell you it depends a ton on what you do for your myeloma and how you approach your myeloma. It's not like we're just, we're just around for the ride and people throw drugs at us, and you just kind of are a passive recipient of all of these medications. I think the approach that is taken to your treatment can have a huge impact on your outcome. And so I think you want to be very deliberate, very strategic. It's like playing a chess match against Boris Spassky and you don't even know how to learn, play chess when you're a patient. So you need to be incredibly, I think, deliberate and strategic and thoughtful in your approach to your myeloma. And I think that can have, I tell you, that can have a very significant impact on how long you'll live. Now, people with myeloma in general, I think the average lifespan is about 8 years. It's a median lifespan. But there are people, that I know that 23, 24 years of myeloma and doing well. A guy that had an allogeneic stem cell transplant, well known in the myeloma community, Jack Aiello, I think is in his 24th year, something like that. So it's a disease where, 20 years ago, we would have been, it's all dismal. Now we live in this incredible era of amazing new treatments, tons of them. And I think, and approaching a point where I think it should be possible to cure myeloma in the not tremendously distant future. So I think there are lots of reasons to be hopeful. I think from my vantage point, I'm trying to stay well enough for long enough so that I can benefit from the next advance in treatment and maybe even a time when there will be a curative therapy. There's been a tremendous amount of enthusiasm around CAR T cells. I see Deb Landis put a question about CAR T cells. They are a big deal for the treatment of multiple myeloma. The first CAR T cell treatment will probably be approved early next year for myeloma. And these treatments can be amazingly effective. But the problem with CAR T cells so far is that they seem not to get rid of it permanently. So you can knock the myeloma from incredibly high levels to undetectable levels. But for the very large majority of patients, the myeloma will come back within a year or two. But I think we're knocking on the door of really massive success. And I think all of us, might want to aspire to just, string things along, do as well as we can for as long as we can until really curative therapies are available.
So I know you just answered Deb's question. The last question I have is, how long can you take weekly dex, and are there any long-term side effect concerns?
Yes, no, that's a great question. No, thanks for that question. So it is, you can take weekly dex for a long time. I took it for about 2 years as part of my maintenance therapy. And, there are some rugged aspects of dexamethasone, the sleeping thing, not being able to sleep well, a lot of times for a couple of days around dex, or for me, it was the day after. I'd take dex in the evening, I'd sleep that evening, but then the following evening, often you wouldn't sleep. It has lots of potential side effects, muscle wasting, weight gain, loss of bone density, lots of unpleasant side effects of dexamethasone. And I think for me, I was just trying to be really deliberate in as much as I could. Thinking about it's one thing, doing it's another, but trying to exercise, stay active, really trying to, maintain my health as well as I could otherwise. Obviously, dexamethasone also increases susceptibility to infections. So I did it for over 2 years, I think. And then when COVID started, I thought, well, let me stop my dex. That might not have been a smart thing, because it turns out dex is a treatment for COVID. So if I'd have been smarter, I could have said, oh, I'm gonna keep on my dex now because COVID's around. But I thought, well, dex makes you, can increase your susceptibility to infection. So I stopped it then. I haven't resumed it. I'm just keeping an eye on my my myeloma markers while I'm on still maintenance with lenalidomide, Rev, and Ninlaro. So, but yeah, there are definitely long-term side effects of dexamethasone. But it's a very potent, it's also a very potent drug. So, it's like a lot of things. It's a kind of balance of risk and benefit.
All right. Thank you so much, Dr. Tony Blau and Dr. Sabel Blau. That is it for all of our questions.
Well,
I wanted to, thank you so much. You guys were wonderful. You always step it up every year and present for us. So we are very, very grateful for you. I wanted to just kind of go over a little bit of information. I will be emailing all the materials that we have on the presentation to everyone who registered. I will also post our presentation. We have been recording this presentation, and Northwest Medical Specialties, we have our own YouTube channel. So I will be posting it on our YouTube channel. You can just go on YouTube and look for Northwest Medical Specialties, and you will be able to see all of our postings and videos that we have uploaded. I also will be emailing everybody a survey about kind of the presentation to see, this is what we use to get our funding. And so we would really, really appreciate if you guys could take the time to fill that out. I also wanted to give you guys a little bit of an update on our next workshops we have coming up. So on December 8th, we have Making Treatment Decisions presented by one of our nurses. So feel free to attend. The registration is available, so it's also like you registered for this one. And we have our holiday party on December 11th. We are very, very excited to be having our holiday party. So if you're interested, please join. And lastly, but not least, is our raffle. So I will be spinning the wheel to see who our winner is, and I will be mailing the winner a gift card, a $50 gift card. So here we go, ready to spin. And I have Jay. So Jay, I will be sending you that gift card. Once again, I'd like to thank you all for coming. I hope you found the information and you had a great time. Thank you. Have a good night.
Thank you, everyone.